what sepsis is, the current state of maternal sepsis in the United States and in New Jersey, as well as how to prevent and detect maternal sepsis in its early stages. It is Black Maternal Health Week, so I want to thank the organization for welcoming me to talk about this important topic during such a pivotal week. Just a disclaimer that there is some intense content in this presentation because of the topic, but it intends to be educational and interactive, so I hope you find it engaging. And without further ado, I'm just going to continue on. Before we get into the content, please use your mobile device to scan the QR code on the screen and fill out a brief maternal sepsis pretest to assess your current knowledge of the topic. I will also post this link in the chat. So you should be able to access it by scanning the QR code or clicking on that link. And because this is a pretest, there will also be a post-test at the end of the presentation so that you can compare and see if you have any improvements in your knowledge. So therefore, you will not be able to see your answers to the pretest, but you can save them for the future to compare to your post-test. So as I mentioned, I put the link in the chat. We'll give this about 5 minutes or until everyone is finished. And when you are done, just put a thumbs up in the chat. Thanks so much. Let me know if you have any questions. Okay, thanks so much for those that put their thumbs up in the chat. We'll give this about 30 more seconds. I don't mean to rush you, but we do have a pretty extensive agenda for today, considering the time constraint. If you are not finished yet, please feel free to continue as we move on, but I'll give it 20 more seconds. All right, I hope that that was enough time and we're just going to move on, but please feel free to finish if you are still working. All right, so thank you for completing the pretest. That really helps us with our data for trainings and webinars. We're now going to move into the session with the learning objectives. So by the end of the session, I hope that you will be able to compare maternal sepsis rates in New Jersey and in the United States by interpreting surveillance data. Identify at least 2 prevention strategies and early detection signs of maternal sepsis, and discuss how timely recognition and prompt responsive care can significantly reduce the risk of morbidity and mortality. And then also be able to describe key maternal health disparities and integrate culturally competent care into your practice. So the aim today is not only to increase awareness of this health problem, but also to encourage you to apply this knowledge directly into your work environment. So, what is septicemia? Septicemia refers to the presence of a pathogen in the blood, and sepsis is an infection that happens when bacteria or other germs enter the bloodstream and spread throughout the body. This is a life threatening condition that progresses very rapidly, which can lead to tissue damage, organ failure, and death. In the context of mortality, the cause of death is septicemia with sepsis implied. And to put this into perspective, sepsis affects 1.7 million Americans and takes the lives of 350,000 every year in the United States. Additionally, 1 in 3 people who die in a hospital setting had sepsis at some point during that hospitalization. The general signs and symptoms of sepsis include dizziness or lightheadedness, shortness of breath, clammy or sweaty skin, extreme pain or discomfort, confusion or disorientation, high heart rate or weak pulse, profound fatigue, and fever or feeling cold. So these signs and symptoms can be challenging to recognize because they often resemble those of other common conditions such as influenza or urinary tract infection. Individuals at the highest risk for developing sepsis include adults aged 65 years and older, children younger than 1 year old, people who have previously survived sepsis, people with chronic conditions such as diabetes, lung disease, and cancer, people with recent severe illness, surgery, or hospitalization, as well as women who are pregnant or postpartum, which will be our primary focus for today's content. So, what these groups share is some degree of immunocompromise, which makes them more susceptible to infections that can progress to sepsis. All right, so now that we have a brief background on this condition, I wanted to highlight data that explains its severity. So, according to the New Jersey State Health Assessment data, sepsis was the 7th leading cause of death in the state as of 2023. This represents an unfortunate increase compared to 2022, when septicemia ranked as the 9th leading cause of death in the state. So it actually went up in recent years. Consistently, nearly 2,000 New Jersey residents die each year due to septicemia, highlighting that this is an ongoing public health challenge. So now that we understand sepsis as a condition overall, we can focus on maternal sepsis, which is also a life-threatening condition defined by the World Health Organization as occurring when the body's response to an infection causes injury to its own tissues and organs during pregnancy, childbirth, post-abortion, or the postpartum period, which is up to 42 days or 6 weeks. So, in essence, it shares a similar definition with sepsis in the general population, but is unique in that it can develop at any stage of the pregnancy or postpartum periods. Maternal sepsis progresses rapidly, sometimes within just a few hours, making early recognition and prompt treatment critical. If signs and symptoms are detected, immediate administration of antibiotics and fluids are essential to reduce the risk of severe complications. Now, looking at the surveillance of maternal sepsis and infections on the national level, this slide highlights the leading causes of pregnancy-related deaths in the United States for 2023, based on the Centers for Disease Control and Prevention's pregnancy mortality surveillance system. So, one of the significant takeaways that is relevant to today's topic is that infection and sepsis accounts for 15.2% of all pregnancy related deaths, being the second leading cause for maternal mortality. This data hasn't shifted much since 2019, where infection or sepsis accounted for 14.3% of pregnancy related deaths when COVID-19 was not included. And just a little bit more data. This slide will give us a bigger picture as to how serious maternal sepsis remains to be in the United States, despite improvements in prevention strategies. So, as mentioned, maternal sepsis is the second leading cause of pregnancy-related deaths. And to put this into further perspective, there are approximately 3.3 maternal deaths per 10,000 births, which contributes to the United States having the third highest maternal mortality rate of all high-income countries. And lastly, 23% of maternal deaths in hospitals are linked to sepsis, which include delivery hospitalizations and postpartum readmissions. So these numbers underscore the fact that while progress has been made in awareness and prevention, there are still significant gaps, particularly in early recognition and equitable care. So, maternal sepsis can arise from pre or postpartum infections caused by a range of conditions, including but not limited to mastitis in one or both breasts, miscarriage, preterm delivery, membrane rupture due to prolonged or obstructed labor, cesarean or C section delivery, non sterile abortion, stillbirth, multiple gestation, such as twin or higher order pregnancies. And then other potential sources include respiratory infections like pneumonia, strep throat, and urinary tract infections. More than half of the women who die from maternal sepsis have at least one chronic or co-occurring condition, such as chronic renal or kidney disease, liver disease, and congestive heart failure. So those are the common conditions, which actually increases their susceptibility to developing sepsis from these infections. The signs and symptoms of maternal sepsis include dizziness or lightheadedness, elevated heart rate, chest pain or shortness of breath, profound fatigue, elevated white blood cell count, and a low blood pressure. I've included the two figures on the screen to re-emphasize that maternal sepsis can occur at any point throughout the pregnancy and postpartum stages. You may also notice that the signs and symptoms are like those of sepsis in the general population who are not pregnant or in their postpartum period. However, pregnancy can mask or obscure these symptoms, and their presentation can vary from person to person. All right, so there are actions that we can take as public health professionals to prevent the development of maternal sepsis and ensure that patients or populations act for themselves to contribute to their own prevention. So during the pregnancy period, it is important that patients stay up to date with routine vaccinations such as influenza. Additionally, if a C-section is recommended, it is crucial to educate patients on how to avoid potential infections, such as keeping the incision site clean and taking antibiotics as prescribed. During the postpartum period, it's important to educate patients on vaginal and perineal tears with how to properly conduct wound hygiene, as well as discourage the use of tampons during that 6-week period as the vaginal canal is healing. And then we have some overlapping prevention strategies here in the middle. And the number one rule in preventing infections, as we all know, is hand hygiene, right? The hands are the most common route of transmission of infection. So it's not only important that patients continually practice hand hygiene, but that we as professionals, if we were to be helping them, practice hand hygiene when assisting. And then also to encourage patients to contact their care team if they suspect any of the infection signs that was mentioned today. All right. So, as mentioned in the prevention strategies section, it's important to act fast after quickly identifying and managing infections that could lead to maternal sepsis. And conveniently enough, many organizations use the acronym TIME to remember the signs and symptoms that should ring the alarm for the early detection of sepsis. So the T in time stands for a temperature that is higher or lower than normal. And I want to emphasize the temperature being lower than normal as a possibility because we typically associate an infection with a high temperature. But in this case, it could also be lower than normal. I is for infection, so assessing for the typical signs of an infection. Mental decline is the next portion of the acronym, especially if the patient is confused, sleepy, or disoriented. And E is for extremely ill, where the patient is experiencing severe pain or discomfort and even expressing the feeling of being deathly ill, right? So most patients can, they know their body, they can distinguish between feeling simply ill as if they had the flu or extremely ill, where they would know that something is really wrong. All right, so now I'd like to review the New Jersey Administrative Code 843G-14.9, which are the sepsis protocols. New Jersey is only one of 3 states to initially mandate hospital-wide sepsis protocols, which started in January of 2018. And they were mandated to improve the early detection of sepsis due to persistently high sepsis mortality rates. So I understand that these protocols may not directly apply to everyone on this call, depending on what setting you work in, but they are important to be aware of and to have some background knowledge on. So these protocols must include screening and early recognition of healthcare and community acquired sepsis. It must include clear criteria to identify patients for whom sepsis treatment is appropriate. The guidelines for treatment shall include adaptations for specific patient populations, and clinical staff must be trained upon hire as well as annually. So while these protocols currently only apply to hospitals within the state, there is legislation upcoming potentially to amend these protocols to expand to different settings as well as expand outside of clinicians. But nothing has been final. All right. So we're going to attempt to play a video. I want to make sure that everyone can hear the audio. So I'll play a little bit of the video before starting it.
We can hear you.
Perfect. Thank you so much. Okay, so we're just going to watch a quick video. It's about 7 minutes, and then we will continue on.
The one thing I 100% knew for sure always was that I wanted to be a mother. I gave birth to Gigi, and we definitely wanted a second child. 4 years later, we decided we were ready. It was 30 hours of labor. We were just having a really hard time. Kalia was just not budging. And finally, they gave me something to induce labor. The most amazing part was them putting her on my chest right away. That was totally incredible. I spent one night at the hospital. We went home the next day. I got home on a Friday and I started feeling really run down. Over the course of the weekend, I just kept feeling worse and worse. I started to feel like I had the flu, incredibly exhausted, trouble breathing. I didn't have a fever, but I had terrible, terrible chills. We did decide to call the OBGYN's office. I was told, very likely you're just dehydrated and you're overexerting yourself. You need to rest more. You need to drink more fluids. So we followed that advice. And then we kept calling because every day it was getting worse and worse. Symptoms included extreme shortness of breath, extreme fatigue, chills. My arms started hurting tremendously and started swelling. My breast milk stopped in the middle of the night, and I had started vomiting. So after 5 days, we finally were able to get an appointment. And they checked my vitals several times because at one point my blood pressure was reading 88 over 40, unbelievably low. So my pulse was at 121. Really scary. Again, I was told dehydration, overexertion, and I was prescribed bed rest and some painkillers. I went in for my exam on a Wednesday. Friday morning, I was blacking out and said, I feel like I'm dying. You feel so horrible. I mean, the worst you've ever felt in your entire life. At that point, we decided we need to call 911.
If she had delayed going to the hospital by an hour, she would have died. If she had gone to a local hospital that wasn't equipped, she would have died.
I was in the emergency room for several hours while they tried to get my blood pressure up.
At one point, she just stopped breathing. They used the paddles to resuscitate her, to get her heartbeat going again.
And then that day, they took me up to the ICU. I barely remember. And then that's it. I don't remember anything. I was in a coma for almost 2 weeks. The first time I heard the word sepsis ever in my life was when I came out of a coma. I was told that I had just survived sepsis and that I had gone into septic shock as a result of what they believed was a strep A infection that I contracted somehow during childbirth. I was at one point on 4 vasopressors, and the vasopressors were used to keep my lungs, heart, and brain functioning, which is why my limbs were black, my feet were black, everything was bandaged, and I had wounds all over my arms and legs. I was extremely close to losing my right leg. It is really a miracle that I didn't die. I got really, really, really lucky. I'd only been out of the coma for a few days, and they brought Kalia to see me. I could barely hold her. I could barely hold the bottle to feed her because I was so weak. It was just so hard to not be able to provide for her and be her mom. It was really hard to be away. I stayed in the ICU for several more weeks. It was all about my wounds, how they're recovering. Am I going to lose my foot? Am I going to lose a toe? The next challenge was learning to walk again. I just kept very focused on the vision of being home. And when that day finally came, yay, I'm home. Happiest I've ever been in my life, for sure. When little Kalia was there, Gigi ran in with flowers and was so excited to have me home, and I was just so happy to be on my couch. In July, we decided that I should have a hysterectomy. My uterus was full of necrotic tissue. I had to go back a week later for several surgeries for skin grafts. Once I was a year out, my right hip started really, really hurting me. Found out that I had a vascular necrosis in both of my hip joints, most likely as a result of all the vasopressors. A vascular necrosis is when the bone dies. So I had both of my hips replaced at age 40. Also found out that I have a vascular necrosis of my right talus bone. I'm young. I have 2 young daughters. That actually caused me a pretty severe depression because it meant that this was forever, that this was never going to go away. I think it's really important for everyone to understand that childbirth is a huge medical procedure. I think there's so much attention put on the newborn, and what a mother goes through, what her body goes through gets very dismissed. If I had known about sepsis before any of this happened, I would have been able to better advocate for myself, really push much harder to say, please take a blood test. I'm concerned that I have sepsis. So it's really important to be a part of that process, not just an innocent bystander, not just someone on the sidelines. You really have to be the leader.
All right. So we're just going to come back. Um, Very intense, right? It's very hard to hear some personal stories of people that have underwent an incident or an event such as this, right? So this video gives us a powerful real life look into the impact of maternal sepsis, not just medically, but emotionally and socially. So this is an example of where the early detection acronym and prevention strategies could have been used in Miley's case, especially when she mentioned feeling like she had the flu and then expressing that she was extremely ill, almost to the point of death, right? Um, and due to the delay of the identification of maternal sepsis in Miley's case, she ended up having multiple long term effects and conditions that have changed her life. But as we have discussed, maternal sepsis is preventable, and it's important to review this information as it can occur when we least expect it. And I appreciate the questions in the chat. I'm just going to go through the content first, and then I'll make sure that we get to it by the end. So this is our list from earlier to show who is at a higher risk for sepsis. As a reminder, because now we are going to dive a bit deeper into the last population on the list. So there are many subgroup populations of pregnant or postpartum women to be especially cautious about in terms of sepsis detection. So the first group of individuals would be women that are 20 years old or younger at the time that they deliver due to factors such as an immature immune system. Women who deliver via C-section, as this is major abdominal surgery, and then women from minority groups, which is our focus subpopulation for today. So back to the data. My background is in public health and research, so I love statistics. But as we have seen, maternal sepsis is a significant health problem in New Jersey and the United States, but there is another layer here that should be acknowledged. So according to the 2016 to 2018 New Jersey Maternal Mortality Report, maternal health disparities were analyzed using a pregnancy-related mortality ratio, or PRMR, highlighting that the highest mortality is experienced among Black non-Hispanic women at a rate of 39.2 per 100,000 live births. Additionally, Hispanic mothers' pregnancy mortality ratio was at a 20.6 per 100,000 births. So this means that Black and Hispanic mothers experience mortality rates that are significantly higher than their counterparts. And to be more specific, this is 3.5 times more likely for Hispanic individuals and 6.6 times higher for Black non-Hispanic individuals compared to their counterparts. So, what does this mean, and why do we see rates this high for minority groups? Well, these ratios reflect systematic inequities that can be explained due to access to care, the quality of care provided, and social determinants of health, or the factors that influence health outcomes. So, this is actually the data that has driven myself and my team to create educational sessions for frontline workers. So there are multiple gaps in maternal outcomes that we see in maternal disparity surveillance. For example, lack of health insurance coverage. We all know how important this is, such as being uninsured or losing Medicaid benefits shortly following delivery, or having limited benefits is a crucial factor that influences a mother's health outcomes. A 2019 study from the Society for Maternal Fetal Medicine showed that having public insurance or being uninsured were risk factors for pregnancy-related sepsis, meaning that patients that could not afford private insurance were at a higher risk. Access to care is another significant gap in outcomes, as access to quality care and access to culturally and linguistically appropriate care play significant roles. Additionally, income and education can serve as gaps, as one's economic stability, their employment, their medical bills or expenses, as well as their previous education, can actually determine whether a woman has positive maternal health outcomes. And then lastly, geographical location is one of the main gaps. There are several factors to consider, such as their housing location, transportation, the walkability of their neighborhood, and community safety. So these gaps in maternal health outcomes are multifactorial, and they have one characteristic in common. They're all underlying social and economic inequities that the public may face, which can be a significant challenge, right? Especially during pregnancy or the postpartum period when they really need some resources. So the iceberg model is a framework that helps to describe the patterns and trends and root causes of health problems. So it uses a metaphor of an iceberg to illustrate how surface level events we observe are underscored by less visible structures underneath. So at the tip of the iceberg, we have higher maternal sepsis rates for minority groups, right? This is what we are seeing in the data and in our quality metrics nationally. Right underneath the water, we have the patterns and trends that support this problem. So, unequal quality of care between patients, higher maternal morbidity in minority groups, and even delayed treatment due to factors like the patient's access to care or short staffing. And then underneath the patterns layer are the systematic structures that are organized practices and institutionalized frameworks that shape someone's access to care. So, as discussed before, this could be income, health insurance coverage, geographic location, and education. And then lastly, we have the root causes at the bottom of the iceberg, as these are foundational contributors that can cause complications at the top, right? And therefore, we want to target them to stop them from occurring. So, some of the root causes that create this health problem of high maternal sepsis rates for minority groups include women's health research, because we still have much ground to cover in this department, but especially more ground to cover in understanding maternal health and the disparities that come with it. Structural racism is also an embedded root cause that contributes to this issue. It's not necessarily individual prejudice, but more of a combination of policies, institutional practices, and cultural norms that advantage some ethnic groups while disadvantaging others. And then lastly, medical mistrust is a root cause experienced by marginalized patients based on historical events. So, for instance, historical stereotypes about Black women being stronger or more pain tolerant actually trace back to slavery era unscientific medical theories to justify the exploitation and mistreatment of Black people. So, to tie this large model all together, the tip of the iceberg is what we can see and acknowledge, as these are outcomes seen in trends and real healthcare experiences. And then beneath the surface is what we don't often recognize and can work to change. So, not all healthcare or public health professionals have the means to change systematic inequities. We know how much effort that would take, but they should be taken into consideration when providing care to all patients or looking at a population as a whole. And then to continue the framework path, a pyramid hierarchy is a great example to explain the feasibility of strategies to prevent maternal sepsis disparities. So at the top, we can all take action to spread awareness about this health issue and ensure patients or populations are informed of their risk to a health condition such as maternal sepsis. With better awareness of maternal sepsis signs and symptoms, patients and populations are more able to recognize dangerous signs during their own pregnancies and know when to seek medical attention. Additionally, healthcare personnel training or public health personnel training, such as what we did today, is vital to staying on top of this condition so that if it does occur for a patient or for a population, we are properly prepared. Evidence-based bundles are a collection of resources to help improve the way that care is provided and therefore improve patient outcomes. Monitoring and data collection is very important, as we know, for any type of health condition or anything that we are tracking, because patient or population data can help us to understand the disparities or gaps where quality improvement efforts should be focused. Of course, practicing culturally competent care by integrating respect, awareness, and responsiveness to patients' cultural beliefs and lived experiences is important, especially in maternal health, where trust and communication are directly influential to their outcomes. And then lastly, advocating for structural and policy changes by using your expertise and patient or population stories to influence decision makers and push for equitable systems of care. Recent data from the CDC shows that nearly 84% of pregnancy-related deaths are preventable. And therefore, this prevention pyramid is especially important to be aware of in the maternal health world. All right. So I am just going to quit sharing my screen for a second so I can move over to the game. In a moment, I am just going to have everyone pull out their mobile devices again. And I'm going to add another link into the chat to bring you to a Kahoot. And let me just pull it up on my screen. We're just going to host it live. I think a lot of people are aware of what a Kahoot is, but I'll briefly explain in a minute once I get this game up. Okay, so once you get to that link, there will be a game pin on the screen once I pull it up, or you can scan the QR code just as you did with the pre-test. Okay, lots of moving pieces. I'm usually Microsoft Teams, so Zoom takes a little bit for me to get used to. But the game pin is 6609879. I'll just put that in the chat. So you could just type that into your screen that you're seeing, and it's going to have you put in your name. So you can make it a nickname or anything that we can have recognizable. But basically, a Kahoot is just an educational activity. There's 10 questions. I'll try to go through them a little fast without talking too much on the explanations. But you'll have about 5 seconds to read the question, and then there will be 4 answer choices, multiple choice, or 2 answer choices if it says it's a true false. So just read the question in the 5 seconds and then pick whatever answer that is matched to the color coordination on the screen that you think is best as quickly and as accurately as possible. So although we are learning, there's a little competition aspect here as well. All right, so we have 13 attendees on today. I'll give it just a couple more minutes because we have 7 people on the Kahoot. And let me know if you're having trouble joining. Okay, we'll give it 20 more seconds, 30 seconds. And if you get kicked out, you can just re-click that link that's in the chat and then put in the game pin again, and you should be okay to keep playing. All right, just for the sake of time, we're gonna move on. We have 10 people. Oh, now we have 9 people. I hope no one's getting kicked out. All right, so just read the question and then pick whatever answer choice you think is accurate. Good luck. Awesome. Everyone got it. So self-explanatory, right? Which of the following groups are more at risk for developing sepsis? Pregnant women who are pregnant or in the postpartum period. The other answer choices have little nuances that make them not correct. All right, great job. Really close scores already. Okay, awesome. Oh, I'm sorry. I don't mean to stress you out. Um, it's supposed to be fun, but I understand, and I know we're almost at time for the session, so I want to kind of breeze through it, make sure everyone gets everything that you're supposed to get out of this session. But don't be stressed out. Just have fun if you can. So which of the following is not a recommended strategy to prevent maternal sepsis? Encouraging tampon use during the postpartum period. We want to discourage for the 6 weeks, right? As the vaginal canal is healing. All right. Some movement here. Great job. True, false. So we only have two responses here. Okay, great. Almost everyone got this correct. The risk of maternal sepsis is 6.6 times greater for Black non-Hispanic women compared to their counterparts. Seems like a very high number, but unfortunately, new data came out. This was actually the 2016 to 2018 time period data. We just got the 2019 to 2023 timeframe data, and now it's actually 7.6 times higher for Black non-Hispanic individuals. So lots of educational sessions that we need to do as a public health field to get that number down. Awesome. Most people got this. I'll quickly go through the other answer choices. So the I in time stands for infection. Illness in the red, I want to stress that someone who is developing sepsis is going to feel extremely ill. Illness could just be they have the flu, even though that could be serious as well. But the person will understand with their own body and should be able to advocate for themselves. And we should lay that foundation or that environment for them to be able to advocate for themselves when they are feeling extremely ill, almost to the point of death. That's the difference with sepsis compared to other conditions. Inoculation, that is the first term that we use to express vaccination. And then inflammation is also too generic for something like sepsis. Sepsis is already a broad condition in itself. So using inflammation to categorize it doesn't work. So I in time is for infection. So temperature, infection, mental decline, and extremely ill. Great job. We have some people on fire. That's awesome. Okay, question number 5. Okay, a little bit of a mixed bag here, but that's understandable. So the answer here is hypertensive disorders, such as preeclampsia and eclampsia. This is because hypertensive disorders are non-infectious and are caused by abnormalities in the blood vessels, not by invading pathogens, whereas sepsis develops when an infection triggers a full systematic body response. So a cesarean or C-section that opens a portal of entry to the body, which puts them more at risk for an infection. Mastitis is an infection in the breast, and pneumonia is a respiratory infection. Okay, so anything that is infectious related. Awesome. All right, moving right along. Okay, great. Yeah. So the correct answer here is to improve recognition of maternal sepsis through evidence-based strategies. Evidence-based bundles are a collection of resources to help improve the way that care is provided and therefore improve patient outcomes. So great job. Most people got that one. Okay, awesome. So this is just a statistic question. The answer here is 23% of maternal deaths in hospitals are linked to sepsis. So this means that nearly 1 in 4 maternal deaths occur as a result of infection that progresses to sepsis. Great job. All right, some switch around. Got a couple more questions left. Okay, great. This one kind of confuses people, but septicemia as of 2023 is the seventh leading cause of death in New Jersey. As previously mentioned, this statistic has increased since the year prior to that, when septicemia was the ninth leading cause of death in the state. So it has increased. Unfortunately, it's at the seventh currently, but hopefully it will not get to the fifth. All right, almost there. Okay, yeah, which of the following is not an objective of an evidence-based bundle? Increasing healthcare facility revenue, not an objective for this prevention, because bundles are designed for quality and for improvement and not for profit. So great job. Everyone got that one. All right, one more question. The tiebreaker for anyone on the leaderboard and anyone actually just playing in general. So I apologize. This was a trick question. Any of the answer choices are correct. So this comes from the prevention pyramid hierarchy, where there were 6 different prevention strategies that can be used to combat disparities, right? So we have awareness and patient education on top that we can do every day, and is very influential, but it could be done every day. And then at the bottom, we have policy changes. That takes a lot longer of a time to implement and a lot more effort, but it is the most impactful. Okay. All right. Great job, everyone. Just quickly recognize those are that are on the podium. Everyone did a great job, though. I really appreciate it. Okay, awesome. Great job. We also have runner-ups at the bottom. Um, and I know we're at time. Let me just make sure I turn this audio off because it's just going to keep going. I know we are at time, but if anyone is able to stay, I can briefly summarize the presentation. But I want to make sure that everyone does their post-test. So I know we're at time. I'm going to send the link in the chat. If you have to leave, please click on that link. It'll take about 3 minutes just to do the post-test and some feedback for
We can
the
also send
presentation.
it by way of email too, Hannah. So we'll do that as well. So
Okay,
putting that out
okay.
there. Thank you.
Awesome. Thank you so much, Kim. So the link is in the chat. We'll send it out. And I will briefly just summarize. I'll just leave actually all of this up. But thank you for playing. Thank you for your participation. I really appreciate it. I hope that the session was valuable and that you learned something today. And ensuring that you have a grasp on the content, just wanted to summarize what we talked about. So the first being that maternal sepsis can be triggered by multiple causes. It's not a single disease because it is a life-threatening response to an infection. Pregnancy symptoms can mask signs and symptoms of maternal sepsis because they are very similar, and it's important to identify a patient or population's risk to be septic through a broadened assessment with public health professionals and the patient's medical team. Maternal sepsis is preventable, right? It's all about the time of detecting it in its early stages to avoid a severe case or mortality. Next, health disparities in maternal sepsis exist and need to be recognized and discussed. In doing so, the patient data that is collected should show better maternal outcomes, and that data can be used to learn from and see what is working in terms of training and education and what is not. And then lastly, educating populations and empowering them to advocate for themselves is crucial, right? So Miley from our video could have had less complications than she did if she had known about the possibility of sepsis and what she can do to minimize the risk following her delivery. All right. You will get these slides. I'll email them over to Kimberly, and I will also send over the link for the post-test. Please, please, please do the post-test because then it tells us what we could do better on our side. I have my contact information here, and I know we're very over time, but I do want to address the questions that are in the chat. Thank you, Andrea, for your questions. So she wants to know if someone had sepsis prior to being pregnant, is it a high possibility they can get it after birth? So yes, unfortunately, if someone were to have a septic event previously in their life, sepsis is really a lifelong challenge. Just like Miley had in her video, she had lifelong complications that affected her for the rest of her life, which is why prevention is so important. Because if we can catch sepsis cases before they occur or while they're just about to develop, we can really minimize those long-term complications. Unfortunately, as I've mentioned, sepsis is really hard to diagnose. It still is because it's so broad, but it's really important to do a blood test so that patients or so that the medical team knows if someone is in early stages of sepsis. Unfortunately, we still see lots of long-term complications, severe cases, and therefore someone is septic before in their lifetime. Those complications they develop after makes them more at risk for sepsis later in their life as well. Does that make sense? It's all about the individual person and their factors, their risk factors individually. And then she also said, how does education play a fact when a Black woman with a PhD is more likely to die than a white woman without a high school diploma? So again, it's all about factors. It's all about the medical team that is surrounding the patient, all about their their willingness to advocate for themselves, the people around them to advocate for them. You've given me two people on two sides of the spectrum, right? Considering the data. Um, it's all depending on that situation itself and what resources that person can get to. If they are in a nice neighborhood, regardless of their education status, if they have access to nutritional food, if they know about maternal sepsis while they're going into their pregnancy. So there's a lot of different things that play into these situations rather than just their ethnicity and their education. Does that make sense? I hope that does. All right. Any more questions? I appreciate everyone staying over
Thank you so
time.
much. Thank
Yes, no
you.
problem. No problem. If there's no more questions, or you can just send me an email with my email on the screen, and we'll get all of that information to you by the end of the day. So have a great rest of your week. Enjoy the sunshine, and thank you so much for having me.
Thank you so much, Hannah. And for those in the chat, as I shared, please note that your evaluation for those who are looking to receive CHES and MCHES credits, you have until April 24th to Friday, April 24th to complete it. And if there's any delays or any issues, please feel free to email me. Thank you for your time. Thank you for participating in observation of Black Maternal Health Week. And Hannah, thank you for all that you do and being a part of a team that's doing the work. And we're grateful for the information that you gave. Have a wonderful day, and thank you again.
Thanks. Bye.
Bye, everyone.
Bye.